Thank you, Gregor. I try to add to the discussion just briefly to Rabbi's question, the first question. We had 2 cases of recurrent pontocerebellar dysplasia, and in both of them we were retrospectively able to demonstrate on volumes that at 22-23 weeks we had a TCD which was on the 3rd centile, but the pons was almost half the size of the normal pons, given the difficulties in getting the imaging of the pons that we were well aware of. But still, in the cases we could manage to see these volumes, and I have one in my presentation on the cerebellar hypoplasia I have to show you if you want afterwards, the pons was half the size of the normal one. So, coming back to the thorny issue for us, were not MRI guys, of Lissencephalies and migration abnormalities here, this is going to be a very hard game for us, not like the one Milan won recently here in Vienna yesterday night. Here you see the brain development timeline, and we are interested, of course, in the migration, and you see that it's going on towards the second part of pregnancy, and this is shown in these nice specimens published in the American Journal of Neuroradiology recently. These are 3 images taken at different gestational ages that tell you the same story. And so the problem for us is that we have the brain just hidden below the calvarium. And this is why we have so many difficulties in assessing the gyration, which MRI guys have to a much lower extent. The planning we get are the conventional one, and you see that also from the simple transventricular one, how the brain changes from 12 weeks to the 3rd trimester. We are quite familiar with that. One of the evidence that you may find in the literature on the web on the first seen or always seen silsa and garai and fissures is this one that you may find on radiographics some 10 years ago. And you see that we're comparing autopsy data with ultrasound data, with MRI data, and you see that unusually the US was performing as good as for the MRI, but at least for these structures here. For central and surface, it's unusually to have this image here and these figures here, because we know that it's difficult for us to assess the surface of the 2 hemispheres. Now I'll move to more detailed analysis with the 3D, and you see that to have a look at the parotoccipital and calcarine fissures in this way, one of the first paper I saw in the literature on ultrasound was by Hans Stoy, who was here in the audience. I met him just before the break, and so he described this image here, and here you see how it can be seen both on parasagittal views, because you have to go at the level of the inner portion margin of the hemispheres, and corresponding coronal view, and you are quite sure that you are at the same level thanks to the ultrasound, 3-dimensional ultrasound correlation analysis. And you see how it changes from the 2nd trimester to the early 3rd to the 3rd trimester, and you see you can assess these features quite nicely in this way. And also the percolorization of the insula can be assessed to a certain extent, both on actual views, as Laurent Guibault has shown you before, but also on coronal reconstruction of coronal views. And again, you see at 20 weeks, 26 weeks, and 30 weeks, how nicely you can assess the insula here, which is going to close with advancing gestational age. And this is again an extreme parasagittal view, showing you the same thing with the insula here, the hypercolorization of the insula. And at the same time, you can get a hint of the cingulate sulcus here. So there is a way to assess these fissures, and this is the base for our assessment of the migration and the cortical malformation, possibly. And we may have a look, and we may suggest people doing screening to have a look while they're doing their BPD measurements and their measurements of the atrial width, to concentrate not only on the big things, which are the atrial width, and to visualize correctly the conceptive pellucity, but also to visualize the initial shy appearance of the fissures, both at the level of the parieto-occipital fissures, here and here, and at the level of the insula, which you can have a look at on this image here. If you train your eyes to consider, while looking at this image, not only the big markers, but also these subtle markers to visualize, then you may train your eyes to pick up also in the second trimester, which is quite challenging, some cases of abnormal migration and or Lissencephaly. Considering what I told you at the beginning on the pathogenesis and timeline of development of the brain, this is why usually, generally speaking, of the various categories of the timeline of diagnosis of cerebral malformations, the malformation of cortical developments are the ones that usually are detected either in the third trimester or only after birth. With only a minority of cases, these were our 700 cases of malformation we published a few years ago, only a bunch of cases detected in the second trimester. Just a few words on the classification. I think the guy who's going to speak after me will go into depth, in details on this. You have an abnormal neuronal proliferation on one side, and you have a normal neuronal migration on the other side. And Lissencephalies are under this heading here. You have two types. There is type 1, in which you have subcortical band heterotopia, and under migration, such as the Miller-Dicker. And the type 2, which is the more typical one, the Cobblestone complex, due to over-migration, such as in Walker-Warburg syndrome. And then you have a third group of cases, the simple Mancomas heterotopias, and we are good only at seeing some subependymal ones because they will indent the outline of the ependyma within the ventricle, and let's show you one case in this presentation. And I will not speak about abnormal cortical organization. What is the evidence from the literature? Well, actually, if you type and search for on the PubMed website for fetus ultrasound and Lissencephaly, you get only 31 hits. Even less than that if you look for Miller-Dicker in the fetus, or if you look for Walker-Warburg. And you see that, especially for Walker-Warburg, all 4 cases which were diagnosed in the second trimester, such as this one, which is from our series, were detected due to, the suspicion was raised due to ocular sign and not due to cerebral sign, which were becoming evident only later on. So, generally speaking, for us, this is really a black hole, because we are able to detect Lissencephaly only when there are so obvious other malformations which are associated, which are so obvious that we may pick up also the Lissencephaly. On the top of that, for example, in this case, you see severe microcephaly in the second trimester, already very severe, and you can see the very smooth cortex at this gestational age. Or in case of low-bar age of the prosencephaly, and again, we do know that in this case you may have Lissencephaly, and here is this very smooth cortex in this case. Or again, in destructive cases such as CMO infection, and also in this case, the depleted neuronal population and the infection will have an impact also on migration, and you may have Lissencephaly in this case as well. Sometimes we do pick them up also without major abnormalities. In this case, there was absent septum pellucidum, and you see in reconstructing this, the surface outline here, you can see this is quite smooth, and also in the coronal image, and there was association with between absent CSP and Lissencephaly at 26 weeks of gestational age. And this is another case of quite evident severe early onset microcephaly and in this case it was detected on the necropsy as clobestrol Lissencephaly. So for Lissencephaly we are not so good, and this is why I will keep my talk short, because I think it's good to admit defeat in this case, if I may say so, and to leave the field to the neuroradiologist. But in some occasions we may detect these abnormalities also earlier during pregnancy. I'm not talking about Lissencephaly anymore, but this belongs to abnormalities of this group of malformation, and in this case you have hemimegalencephaly. This was a BPD at 22 gestational weeks, which you may pass for normal, but if you measure not as so much so at the level of the thalami, which was roughly the same size, the two hemispheres, but on the frontal you see that there was a significant distortion on the forks here, and the size of the two hemispheres was quite different. We turn our transducer, and you see that on the coronal view transabdominal, and was not a very thin lady, not a model. You see here that the forks was giving us quite clearly the diagnosis of hemimegalencephaly. And then we turn to transvaginal neurosonography, and here you see on one side you have an ependyma here, and you have a subependymal heterotopia, and on the other side this is a coronal scroll through the two hemispheres, and you can see here how abnormal is these hemispheres, and you see the sides, and you see all the features. Look at here, the difference, which give the definition and the diagnosis of hemimegalencephaly. And this is also the construction of the axial view, and you see the Sylvian fossa, the Sylvian area is also involved. See how different it is from one side to the other. And so in this case it was possible to detect hemimegalencephaly during the second trimester, but this is quite the exception. Usually also for hemimegalencephaly, most of the cases are detected in the early third trimester. And also polymicrogyria here, if it's quite clear and and the abnormal foci are quite deep, we can pick them up also in the second trimester. This was 22 weeks, and you see here the abnormal location here, and was this image here. So we are not as good, that good at picking up the Lissencephalies. We may see them when there is another obvious abnormalities associated with that, and if you have microencephaly, which give us some enhanced visualization of the cortex, because there is an increased subdural spaces which enhances the acoustic window. This is why if you have microencephaly, you have more evidence on ultrasound of possible lissencephalic brain. Or you have very obvious abnormalities in the location, and in this case we are more sensitive. We're picking up the accuracy is a bit higher than for lissencephaly, and the same applies in case of polymicrogyria, even though polymicrogyria will develop after birth in a clear way, but in some cases our data were matching the data of the neuroradiologist, and so we learned by sharing the experiences how to see these abnormalities and this sign that would lead to polymicrogyria after birth. So in conclusion, the early diagnosis, by early I mean less than 22 weeks, which is the crucial term for legal termination in several countries, can only be made in very exceptional cases, only if other major malformations are present, and I showed you some examples. In the borderline period between 22 and 24 weeks, it begins to be possible, but subtle signs should be picked up and recognized on screening. And this is, frankly speaking, quite unlikely, because we should be quite brave and trained to pick up those signs at 22 weeks of gestational age. And also in that range, it makes a lot of difference if you are seeing a brain at 21 weeks or 23, 24 weeks. So it would be feasible in high-risk cases in which you have recurrence of the brain lesion, because these cases are managed directly at tertiary center, where the true ones actually, and I have a last slide for those of you who will have some entertainment on the next days in one of the workshops on the brain. The true fetal medicine center in tertiary center will do neurosonography with a transvaginal approach. After that period, it may be feasible. The later, the better. The sensitivity will be much higher. But as I was telling you before, it's a challenge for those countries such as Italy, in which you have a legal termination not available after 22 weeks of gestation. And this is my last slide. If you have some fun, there is a workshop coordinated by Gustavo Malinger on Sunday dealing with this. I will omit the adjective, this study published recently in The Lancet, which is a shame for all of us. Thank you for your attention.
So thank you. These were wonderful images. And I think we just continue with Christian Mitter, who is going to present the MRI perspective of Lissencephalies.
So I want to wish you an interesting afternoon. I hope you're having fun at this course. Topic of the next 15 minutes will be fetal MRI of lissencephaly. And as you probably all know, that the classifications of lissencephaly changed a lot in the last years. And with every year, they seem to get more and more complex. So in one of the more recent imaging classifications, the authors were able, for example, to differentiate 20 imaging patterns in various forms of lissencephaly in postnatal MRI. Now in fetal MRI, we're not there yet. And it is also probably not your main objective as a prenatal diagnostician to differentiate tubulinopathy from a LIS1 mutation on a fetal MRI. But what your job is when you're doing fetal MRI is when you look at a brain like this one that looks a little bit odd, to be able to tell if this is a normal brain or not, if this shows signs of lissencephaly or not. And therefore, we will be a bit more general in this talk and look at imaging findings that are generally associated with various forms of lissencephaly that can be seen in fetal MRI, and that should tip you off in this direction, so that you, when you see a brain like that, can say, no, that brain isn't normal. That's a lissencephaly at 22 gestational weeks. The postnatal imaging criteria for lissencephaly on MR can be grouped into these 4 groups. First of all, you have to describe the grade of gyral malformation. So if you have an H area or a package area, then the gradient, is it diffuse, is it anterior, posterior predominant? You look at the cortical thickness and the appearance of the cortex, and as well, you look at non-cortical brain malformations, because lissencephalic syndromes are whole brain malformations. They not only involve the cortex in a lot of cases. In the fetal brain, it is, of course, a bit more different, because fetal brain is still developing. So there are also structures that we have to take a look at in addition to the postnatal criteria. So in fetal MR, we have to look at the parenchymal lamination of the cerebral hemispheres and at the ganglionic eminence, where the proliferation of GABAergic neurons for cortex and deep nuclei takes place. And of course, we also look at sulcation and non-cortical brain malformations. So we won't spend too much on looking at sulcation in this talk. Sulcation can be very well assessed on fetal MRI, as you see here. And as you can see here, it is predominantly a third trimester process, the formation of the sulci. Whereas in the second trimester, there's actually not that much of sulcation going on. There is the parieto-occipital sulcus and cingulate sulcus, but apart from that, there's not much duration. So in second trimester, it's generally advisable to not really look at the sulcation pattern, but at the opicularization, so at the continuing formation of the sylvian fissure. Opicularization is the continuing folding of the frontal, parietal, and temporal lobes over the insular surface, and this is pretty consistent. So when you have a fetus with lissencephaly, and all of these fetuses are lissencephaly, it is always advisable to have a set of normal control brains for each gestational week at hand, with which you can then compare your sulcation pattern. Obviously, in this case, which is aged 35 gestational week, that's not very difficult to diagnose here a gyration abnormality. This is a diffuse agyria and is very much pronounced different to the normal control brain. This one is 30 gestational weeks. We see it has a pronounced reduced opicularization compared to the normal control brains. And in addition, in the normal brain, we can see the collateral sulcus, the cingulate sulcus, also here the central sulcus, which we can't see in this brain. But when we look then at this brain, this fetus is 22 gestational weeks old, and here we don't see much sulcation in the normal brain. So the only thing that we can look at to look at a delay of sulcation or gyration is the opicularization. And as you see here, the opicularization is actually reduced in this case compared to the normal control brain. Now, lissencephaly not only includes syndromes that have a very smooth cortical surface, but in contrast, there are also types of lissencephaly that have a bumpy surface. So-called cortical bumps can be seen with fetal MRI quite nicely, actually, as these tiny irregularities of the cortical plate, as you see here. And these cortical bumps are a hallmark of the type 2 or cobblestone complex lissencephaly. Cobblestone lissencephaly is not a disorder of arrested migration, but a disorder of overmigration. So neural precursor cells migrate from ventriculus onto the cortical plate, but they don't stop here, but instead continue their migration into the leptomeninges, where they form glioneuronal heterotopia. And this heterotopia can be seen as these bumpy irregularities of the cortical plate. This is another case of type 2 lissencephaly at 22 gestational weeks. We see a very subtle findings, and with increase of gestation, these findings generally tend to get more and more pronounced. Just like a normal sulcus gets more pronounced with gestation, also abnormal gyration gets, of course, more pronounced. And here in the postnatal scan of this fetus, you see here a very pronounced bumpy surface of the brain. And this was a genetically proven case of muscle-eye brain disease. Other forms of abnormal gyration include dysgyration, for example, here in this case of microlissencephaly. So please note the bumpy irregularities of here the frontal lobe. And of course, there are not only bumps on the outside of the brain that you can also see bumps on the inside, on the ventricular lining of the brain. So subepidermal heterotopia also results as in a defect of migration, and they can be seen as these irregularities of the ventricular lining. But to be fair, due to the limited resolution of fetal MRI is actually not that sensitive in the detection of subepidermal heterotopia. So they're easily missed, and there are probably many cases in which we don't see anything on fetal MR, and in which we then can, for example, in histology, prove that heterotopia are actually present. Then, of course, many cases of lissencephaly have enlarged ventricles and hippocampal malrotation, but keep in mind that this is a rather non-specific finding. So if you see a hippocampal malrotation, for example, here it is 25 gestation week old fetus, it should tip you off to look more detailed, not only on the ventricles, but also on the lamination of the parenchyma and so on. It could tip you off to find a much more pronounced cortical malformation that you would just suspect by looking at the ventricles. Now, very important when it comes to fetal MRI is the parenchymal lamination of the telencephalic wall. And when we look at one of the most important forms or well-known forms of lissencephaly, the classic or type 1 lissencephaly, the hallmark of this disorder is a thick and poorly organized 4-layered cortex. Type 1 lissencephaly is a migration disorder, a disorder of arrested migration. So cells proliferate in the ventricular zone, but they don't then migrate into the cortical plate, but they arrest the migration somewhere in deeper layers of the telencephalic wall. So what you have in these disorders is a higher amount of nerve cells or cells generally in deeper layers of the cerebral wall and a rather thin superficial cell layer. Just to repeat quickly how lamination looks at fetal MR. On T2 weighted images, you've seen that today ventricular zone and ganglionic eminence is dark. Intermediate zone has an intermediate signal intensity. Subplate is rather bright, and cortical plate is again rather dark. Lamination can not only be seen on T2 weighted images, but also on diffusion weighted images. In diffusion weighted images, the ganglionic eminence and the ventricular zone is bright. Intermediate zone is also very bright. Subplate is dark, and cortical plate is again very bright. So keep these patterns in mind. But how can we understand these signal intensities of the different lamina of the telencephalic wall? Well, the T2 weighted contrast is predominantly dependent on the cell density of the tissue. So when we look at histological slice, we have two cell dense areas in the brain, the cortical plate and the ventricular zone, and they are therefore both dark on T2 weighted images. The subplate, on the other hand, is a very cell sparse region, and also has a high water content, so it is very bright on T2 weighted images. And the intermediate zone contains a lot of migrating neurons and also a lot of tightly packed axons, and tightly packed axons also have a somewhat reduced T2 weighted signal. So now when there is an arrest of migration, as in a type 1 lissencephaly, you have more neurons here in intermediate zone and subplate. So what happens is we have a blurring of this subplate and intermediate zone layers. And in addition, you have a thin, dark, superficial cell band, because actually a lot of cells that are in the cortical plate in a normal fetus are somewhat arrested here in the deeper layers. Now, these images have been shown in a couple of presentations today, but the unfortunate thing is that no one has actually yet explained to you how to interpret those. So what you see here is post-processing of a photograph of a histological slide, which is processed with mathematical algorithms that are actually similar to the algorithms used in diffusion tensor imaging. But instead of diffusion, you look at directly the fiber orientation. And what the color scheme of this image shows you, so the hue shows you the orientation of the fibers. So red fibers run like that, like here. And green fibers run like that, like here. Blue fibers would run like that. And the saturation of the color represents the anisotropy. So the saturated the color is, the higher the anisotropy in this region. And what this basically shows you is that in the cortical plate, you have a high radial anisotropy. In the intermediate zone, you have a predominant tangential anisotropy with some radial crossing fibers, of course. And in the subplate in between, you have a rather low anisotropy because you have a dense network, a meshwork of fibers, and not thick bundles of thalamocortical or corticospinal fibers as in the intermediate zone. And this is basically what contributes to diffusion-weighted signals. So diffusion-weighted signal is, of course, also dependent on the cell density, but also on the anisotropy of the underlying tissue. So you have a high signal in the cortical plate, a low signal in the low anisotropy subplate, and a high signal in the intermediate zone. And you also have a high signal in the ventricular zone and ganglionic eminence, and we will get to that in a few minutes. So if we now compare this fetus, which is a type 1 lissencephaly, to this normal control brain, and if we look at the parenchymal lamination, we first see that the parenchyma in the lissencephalic fetus is thicker than in a normal fetus. And in addition, there is an abnormal lamination. It can be seen both on diffusion-weighted image as in the T2-weighted image. You see here, while in the normal fetus you can differentiate subplate from intermediate zone, you have here a blurring of subplate and intermediate zone. And if you compare the normal cortical plate, it is in the lissencephalic fetus very thin because most of these neurons are arrested in migration somewhere in deeper layers. This is another example of a type 1 lissencephaly fetus. You see here a thin superficial cell layer, no lamination. But what you can see here in this fetus is that there is actually a gradient of the disorder. So when we compare the frontal lobe to the temporal lobe, there is actually a more well-developed cortical plate in the temporal lobe than in the frontal lobe. Also here on axial images through the temporal lobe, it doesn't look that bad. But when you look at this temporal lobe on diffusion-weighted image, you see here in the normal control fetus a normal lamination, while here the lamination is completely abnormal. And this would be the same case at 30 gestational weeks. Now, very important structure in the fetal brain is the ganglionic eminence. And it is there where the proliferation of GABAergic neurons, of GABAergic projection neurons of the deep nuclei and of GABAergic interneurons of the cortical plate takes place. They proliferate here and then migrate tangentially to the cortical plate. Pathologies of the ganglionic eminence that can be seen in cases of lissencephaly include abnormal enlargement of the ganglionic eminence, as can be seen in those cases. Here you have control cases. And in some cases, you also see gaminolytic cysts within the ganglionic eminence in fetuses with lissencephaly. And one of the interesting things of the ganglionic eminence is that it is a very anisotropic structure. So there is a directed diffusion in the ganglionic eminence, just like in a white matter fiber tract. This has been first described by Huang et al. In 2006 in Postmortem Brains. But this high anisotropy in the ganglionic eminence can also be used in fetal MRI to perform a tractography in the ganglionic eminence. But keep in mind that those are not white matter fiber tracts that you visualize here. This is just a three-dimensional representation of the anisotropic architecture of this structure. So remember the kidney that Gregor showed you, the fibers that you see in the kidney, they're also not white matter fibers. They're just three-dimensional visualization of the anisotropy. And this is similar to that. So what you see here are pseudofibers. It is currently not known what creates this anisotropy, but we can measure it and we can perform tractography. And by doing tractography, we can look if the anisotropic architecture in this region is normal or disturbed. This is a case that we imaged at 29 gestational weeks. And when you look at the ganglionic eminence, in this case, it is very enlarged. And when we perform tractography with DTI in this ganglionic eminence, you see here that it is not so smooth as in the normal fetal brain, but it is somewhat irregular, and there's a breakup of fibers in between. So at 29 gestation weeks in this fetus, we saw ganglionic eminence enlargement and abnormal anisotropic structure of the ganglionic eminence. This fetus then returned at 34 gestation weeks, and what we now see is a frontal pachygyria. If you compare this frontal lobe to the normal control brain, you see there is actually slightly more gyration in the control brain than in our brain. And these are postnatal MR images from this child at the age of 7 months. Now you only see a very slight reduction in gyration, probably, but what you see is an enlarged frontal horns of the ventricles, and you see these structures here, which are actually remnants of the ganglionic eminence, and this child has an untractable epilepsy, presumably because GABAergic interneurons did not migrate from the ganglionic eminence towards the frontal lobe. Now, besides sulcation, opercularization, and cortex itself, it is also important to look at non-cortical brain malformations in cases of lissencephaly, including disorders of the basal ganglia, agenesis of the corpus callosum, tactile hyperplasia, brainstem hyperplasia, and cerebellar hyperplasia. It is always important to look at white matter development in fetuses with lissencephaly, and one of the most important white matter areas in the developing fetal brain are the so-called periventricular triangles, which is this area here at the exit of the internal capsule between the putamen and the caudate nucleus. And this is an area of crossing fibers of internal capsule, external capsule, and association fiber tracts with a lot of different fiber tracts coursed through this region. It can be sometimes seen as a slightly hyperintense area in younger fetuses, but when it is pronounced hyperintense, like in that fetuses, or it is persistent in older fetuses, it is very often a sign that there is something pathologic in the development of the white matter. And this is also not specific for lissencephaly, but if you see this in a fetus, always also look at parenchymal lamination and so on, because it could be a more complex brain malformation. Here you see normal 21 gestation week old fetus. And here
Christian, can you please come to your conclusion?
Here one fetus with lissencephaly, where you not only see abnormal triangles, but also callosal agenesis. That's a case of X-linked agenesis with X-linked lissencephaly with agenesis with ambiguous genitalia. And just very quickly, infratentorial, you look at kinking of the brainstem, then abnormal shape of the brainstem. You look at the tectum, if you see tactile hyperplasia, which happens in some cases of lissencephaly. And of course, you look at pons and cerebellum. All of those are, of course, not specific for lissencephaly, but should maybe tip you off to take a bit more of a closer look also on the telencephalon and in parenchymal lamination, and think, could this be a lissencephaly? So here, take-home message to wrap it up. In case of suspected lissencephaly, you look, of course, on sulcation, but also on parenchymal lamination, on a ganglionic eminence, on abnormalities of white matter development, and on non-cortical brain malformations, especially in the posterior fossa. Okay, thank you very much.